Good afternoon. This is Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you for joining today's Kentucky SOS webinar entitled Perioperative Opioid Stewardship, Changing the Culture. We will begin shortly. Good afternoon. This is Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you for joining today's Kentucky Statewide Opioid Stewardship webinar entitled Perioperative Opioid Stewardship, Changing the Culture. I am happy to also introduce with KHA, Claire Arant, who's on the webinar today, and pharmacist Stacy Allen. Please mute your lines at this time if you have not done so. However, at the conclusion of the webinar, you can unmute your line and feel free to ask questions over the phone. You may also utilize the chat box for questions during the presentation, and the presenters will get to your questions accordingly. As always, the presentation slides and recording webinar will be posted on the Kentucky SOS website for your reference or to share with colleagues about 1 week after today's webinar. I will also email all the Kentucky SOS project leads, the slides and recording once it is posted on the website. So I'm delighted to welcome you today to today's Kentucky SOS webinar entitled Perioperative Opioid Stewardship, Changing the Culture. This webinar is the third in a series of 4 monthly webinars, which will end next month in July, which have focused on the following topics: physical therapy as an alternative to opioids, inpatient multimodal analgesic order sets, today's webinar, and lastly, proper prescription disposal and education. Kentucky SOS collaborated with Baptist Health clinicians for this webinar series, and it exemplifies best practices for opioid stewardship program. It's been a true multidisciplinary approach representing pharmacy, physical therapy, nursing, and medicine disciplines. Today, I have the honor of introducing the speakers from Baptist Health Lexington, Dr. James Borders, Lindsay Bowles, John Edwards, and Emily Saka. Dr. James Borders graduated from UK College of Medicine and pursued internal medicine internship and residency at Baylor University Medical Center in Dallas, Texas. Borders practiced internal medicine and private practice in Texas, then returned to Lexington in 1988 to practice internal medicine. He has been CMO at Baptist Health Lexington for 7 years. Borders is the chair of the executive board of the Lexington Medical Society and has chaired Kentucky Medical Association's Council for Continuing Medical Education for 31 years. Lindsay Bowles is the Enhanced Recovery After Surgery Nurse Coordinator at Baptist Health Lexington. She has been a nurse for 22 years. Her experiences include working at Baptist Lexington in med-surg, telemetry, and cardiac rehabilitation. She began her role of ERAS nurse coordinator in February 2018, growing the program which now has 8 active ERAS protocols. Lindsay also stays actively involved in helping to lead Baptist Health System with colorectal, cardiac, and OB C-section enhanced recovery protocols. John Edwards earned his Bachelor of Science degree from Murray State University in 1996 and his Master of Science in Anesthesia from Middle Tennessee School of Anesthesia in 2002. In August of 2021, he completed his Doctor of Nurse Anesthesia Practice degree at Middle Tennessee School of Anesthesia. John has been practicing at Baptist Health Lexington since 2004, where he co-founded and co-directs an acute pain service. He is also the co-founder of Thoroughbred Anesthesia Academy and is an adjunct faculty member at Middle Tennessee School of Anesthesia in the Acute Surgical Pain Management Fellowship. He is a member of several medical professional communities. As the chair of the Acute Pain Committee, John has led the development of Baptist Health's acute surgical pain management guidelines and acute order set to provide a comprehensive approach to acute surgical pain management. Emily Saka serves as Assistant Director of Rehab Services at Baptist Health Lexington and has been a practicing clinician in the acute and outpatient care setting for the past 12 years. She is a member of the Therapy Technical Advisory Committee for the Kentucky Cabinet of Health and Family Services and a longstanding member of the American Physical Therapy Association. She received her BS from Murray State University and Doctorate of Physical Therapy from Bellarmine University. Her clinical focus has been wound care, early mobility promotion, and leading and implementation of a nurse-driven mobility program across the Baptist Health System called ANPAC 6 Clicks. So Kentucky SOS welcomes Baptist Health Lexington clinicians. Thank you.
Well, thank you, Emily. That's a very nice introduction. I appreciate the opportunity to come before this group today to share some of our experience at Baptist Lexington. So none of our planners for this or faculty have any relevant financial relationships to disclose. The objectives for today will include the use of enhanced recovery after surgery protocols to reduce the primary reliance on opioids in the perioperative arena. We'll discuss outcomes associated with enhanced recovery after surgery protocols and use of Baptist Health Lexington. And we'll describe efforts related to the reductions in postoperative opioid prescribing at Baptist Lexington. So since 1954, Baptist Health Lexington has been serving their community. Today, we are a nationally recognized community hospital serving over 40 counties in central and eastern Kentucky. We view ourselves as an integral part of this region and its public health concerns. And we are absolutely committed to working towards the prevention, protection, and education around the opioid epidemics in our communities. So if we think about the opioid epidemic, opioid-related overdose deaths, including those involving prescribed opioids, continue to increase in the United States. Data from the CDC reported nearly 100,000 drug overdose deaths during a 12-month period ending June of last summer, and those numbers have escalated since then. These numbers reflect that approximately 275 people die every day in the U.S. from a drug overdose, an 18% increase from the previous year. And in Kentucky, 2,300 people died from a drug overdose during the same time period, reflecting a 35% increase. Now, although opioids effectively manage surgical pain, the misuse of opioids, defined as taking a medication for a purpose other than prescribed, can lead to opioid abuse, addiction, and life-threatening overdoses. A 2017 systematic review evaluating prescription opioid use following 7 common surgical procedures revealed that 67 to 92% of patients had leftover opioids after their surgical pain had resolved. Now, these surplus medications are the primary source of misuse and diversion for non-medical use. We know that most individuals who have misused opioids obtain them from family members or friends who've leftover medications in their medicine cabinets. And it's these excess opioids remaining after surgical procedures circulating in our communities that contribute to the opioid epidemic. So one of the things that concerns me quite a bit is this concept of new persistent opioid use. And we define new persistent opioid use as people who come for surgical procedures who are opioid naive, have a surgical procedure, and at 90 days and beyond postoperatively, they're still using opioids. Now, this isn't always about acute pain or new chronic pain. It's really a new complication that's happening after surgery. So there's a few studies here. The group up in Michigan by Brummett et al. Found in their surgical population, 6% of patients, opioid-naive patients, develop new persistent opioid use. In a hip and knee study, 8% of patients. In a hand surgery study, which you would think hand surgery is kind of a more minimal, small procedure, 13% of those patients develop new persistent opioid use. Spine surgery, 13%, and that kind of makes sense. This is really adolescent patients having sports medicine in this study. 5% of those patients are developing new persistent opioid use. This is a cancer study finding 10% of patients. And in this study, 19% breast cancer patients develop new persistent opioid use. So this is a big concern of ours. It's a big concern of mine. And so we really want to look into that today. So how can we prevent new persistent opioid use before it starts? So what happens is we have opioid naive patients, meaning patients not on opioids prior to surgery. They come in for surgical procedure. Let's say they're having their gallbladder out. And even in 2022, they get discharged with an appropriate amount of opioid medication, say 15 to 20 pills. And over the course of the next week or two, they might use 3 or 4 of those for their surgical pain. And after that resolves, those medications are left in medicine cabinets in our communities for 2 things to happen. One, people can misuse those opioids, meaning at some point in the future, they may have debilitating headaches or stress in their life. Insomnia, those type of things. And I begin to remember, hey, I've got those medications in my cabinet. I think I'm going to take one of those tonight to help me sleep or to help me with this bad headache that I have or the stress that I have in my life. Or the second thing that can happen is those opioids get diverted into our communities out of those medicine cabinets and end up in our schools and in our workplaces. And both of those things contribute to the opioid epidemic. So authors of a recently published paper this year in January of 2022 entitled Responding to the Opioid Crisis in North America and Beyond, Recommendations of the Stanford Lancet Commission estimated that without new action or initiatives to address the opioid epidemic, the next decade would bring 1.22 million deaths, or an average of nearly 336 people dying every day from an opioid overdose. Now, historically, when you've read manuscripts or studies published really around the opioid epidemic, they often kind of the standard number they quoted was 130 people die every day. Now with the coronavirus pandemic, those numbers have gone up to 275 people a day. And now we're talking, if we do nothing new over the next decade, it's going to be 336 people a day. So these numbers are really escalating. And so the Stanford Lancet Commission discussed that the prevention of new cases of opioid addiction is essential. Therefore, those of us in the perioperative arena need to work towards the implementation of an evidence-based best practice that enhances pain management while reducing the primary reliance on opioids. So how do we do that? And the first thing that we want to do, and I want to stress here, is that we want to manage patients' surgical pain very well. Okay, I want to stress that we are not trying to be an opioid-free facility. We believe that opioids play a role in the acute surgical pain management arena, but we want to make sure that we're managing people's pain extremely well through things like I direct our acute pain service. We do over 5,500 regional anesthetics every year for patients having surgery in our facility. We've got a great PT department that we'll hear about here soon that talks about how they use non-opioid approaches to managing pain. We've developed an acute surgical pain management order set similar to what Dr. Oliver talked to you guys about last month, on really making sure that our non-opioid medications are scheduled around the clock and those type things. And all of these things allow us to eliminate unnecessary opioid exposures. I've been in anesthesia and acute pain management for 20 years. And when I first got into this world, it was, patients were having pain. Preoperatively, we gave them opioids. Intraoperatively, we used a lot of opioids. Pain in the PACU, opioids. Pain on the floor, more opioids. That's called opioid monotherapy. And that's really unnecessary use of opioids when we're not really looking for non-opioid ways to manage pain. And that allows us to reduce opioid use when necessary. And hopefully, by putting all these things together, we can eliminate new persistent opioid use and then prevent the diversion of opioids into our communities, which is what I'll talk to you guys about next month. So next, I want to introduce one of our great team members here, Lindsay Bowles. And Lindsay, as you heard, joined us in 2018. And we'd already had some enhanced recovery after surgery protocols kind of working. But what we realized was that it really is going to take someone who can own that, right? And whose kind of like their whole world revolves around development and management of these enhanced recovery after surgery protocols. And so I was very appreciative of the support of the administration of Baptist Health Lexington and recognizing that we could do more with some staffing for this. And so Lindsay joined us, and I want to introduce her now to kind of share some of the things that she's done and that we've all collaborated on to do together. Lindsay?
Thank you. Thanks, John. Yes, as John said, and Emily in introducing me, I'm the ERAS nurse coordinator here, and I've been in this role since 2018. And really, when I jumped on board with this team, we were already doing some enhanced recovery protocols late 2015, early 2016 is really when it got started, more with orthopedics, and then they kind of moved from there. There we go. So for some people that do not know what ERAS is, or enhanced recovery after surgery, these are the protocols that are evidence-based. They're designed to standardize that medical care for patients, improve the outcomes that they're having, and then achieve the early return to daily living. So the activities that they were doing, we want to continue to see them achieve those goals after, or at least get back to baseline. The enhanced recovery program really serves as a pathway for patients. There are so many patients who I've talked to going in to see them that say that they were very well prepared and way more prepared than they have been with prior surgeries. They felt like it was a pathway for them. They knew what to expect, that along the way, the whole team knew what was going on in each facet of their care. Everyone was involved in the care, and they knew the different components. Those key components of the pathway come together, which lead, of course, to better benefits for our patients. So why enhanced recovery? Why are we asking patients again to move a little sooner, maybe chew gum, decrease their opioid uses, and do what's called a multimodal? So putting medicines together in combination, and how does that really work? And why is that different than what we used to teach them before? Also teaching them to better assess their pain and taking numbers on that pain scale and making the pain scale really hit home with them. So maybe if my pain's a 4, I would really get the nurses to be talking to the patients about associating that number with what kind of medication they should be taking at that time. So by giving the patients these tools and teaching them about early ambulation, decrease in opioids, and all the things that we're doing with enhanced recovery, we're empowering the patients. We're getting them ready to go through their surgery. We're also empowering the family members who are part of their team, right? They're doing the right things for themselves. So making them a key part in their own recovery is number one. Our job is to give them the tools to do so. By having an enhanced recovery nurse coordinator, I work as the liaison between the office, the pre-op, the PAT, and then to the nursing floors. And because I have a nursing background of being on the floors, workflow and working with CIT and the order set really is nice because I get the opinions from all sides, and I can kind of connect the dots. I hope, at least I hope I do a good job of connecting the dots. Also, I think once I became a part of this team and working as the liaison, we also saw that you can get stuck in your certain area, or as we like to call them, John writes, your silos of different areas, and you forget how that impacts the next place that the patient is going to. So from the office to PAT, then to the pre-op, and then eventually to the floor and to home, how that all comes together and makes for good outcomes for patients. So the enhanced recovery pathway starts in the surgical consult and continues through discharge, just like what we talked about. So that surgeon opens the door of conversation as soon as they're in there for the surgical consult. The goals for enhanced recovery that we came up with here in Lexington are to prepare you for surgery physically and emotionally. We want better pain control with fewer side effects. That's the goal. Again, like John mentioned, we're not saying that we're not going to give you any narcotics. It's how can we offer you maybe that option of a different pathway if maybe there's a history there. We've had several patients that are talked to in PAT because they've mentioned they have an issue or a history, or maybe they live with someone that has an issue. So we address it at that time as well. Eating sooner after surgery, increased early movement and walking. We know that that is a huge piece in when they get out of here and if they are feeling better, able to move around easier. And then shortening their hospital stay and return to normal activities. So enhanced recovery, whenever I do teaching with anyone on what it is, I teach in 3 phases. So you have preoperative, intraoperative, and postoperative. That good office education, screening in PAT, and optimizing that patient. So maybe smoking cessation, alcohol cessation, talking about their weight, if there's enough time in there to have those good discussions. Really promoting compliance with the program in its entirety. And then intraoperatively using that multimodal analgesia. What is multimodal? It's where you take that combination of maybe Tylenol and an NSAID, giving the patients other options for not using as many narcotics or minimizing those opioids. And then postoperatively, early feeding, early ambulation, and a good multimodal. And of course, minimal lines and drains. So we're getting those lines out and drains sooner. The next diagram really shows how it all works. Sure, I'm the nurse coordinator, but it takes having an ERAS care team, which is a multidisciplinary team that I meet with about now every other month. Different groups are represented on that team, and it gives me a great idea to get education involved. There's a pharmacist, there's the OR coordinator. Those are all people that are a part of the team. And then of course, nursing is huge, anesthesia, and surgery. So you got to have those surgeons on board. We wanted to share some of our success at Lexington with you all today as well, just to show you the impact that this has had on us here, and really the passion that's kind of driving all this is when you see the numbers, it really puts it, hits home and shows how successful a program can be. We have currently 8 active service lines, with the cardiac service line just going live, so that makes 9. And the ones in black, so colorectal, breast, urology, and OBC section, we're going to touch on some of that data. This one I just wanted to pull. It was our fiscal year of 2020. And what we did was we pulled our data from, these are all our Baptist Health hospitals, and I've highlighted in red Lexington for us. You can see the non-ERAS cases that they pulled, their length of stay, 8.59. And then as we went along in Q1, 2, and for the year, we've really averaged our length of stay between like 3.88 and anywhere and up to about 5. And then the cost savings is just pretty great too. The next one we want to show you was our OBC section. ERAS go live date for that was actually in the peak of COVID, November 25th, 2020. This is actually just 1 month worth of data. So November to December that they pulled, because we really just wanted to get a good, clear look of what was happening right away with that protocol. It had only been running for about 4 weeks when we pulled this data. We decreased the morphine equivalency by scheduling out those medicines and doing a multimodal protocol. We decreased the morphine medication equivalent by 40%. We decreased their length of stay by 11%, which we never thought that we would move really the length of stay, because we don't have a huge length of stay with OBC section. And we did, which added an additional 44 days of bed availability open to other patients. And then of course that added a direct cost savings. And if you look at the total MME, that went from 77 to 46.4. This next slide I'm really proud of, because we not only have kept our morphine equivalency down, besides just that one peak month, which you can pull the individual patients and kind of look and see that we just had some higher patients with some different issues going on and some pain issues happening during that month, because we did see that peak there. But really, if you look at the data from August of 2020, you start to see a trend down. We originally thought that we were going live with this protocol in Epic in October of 2020, and the order sets actually went live in November of 2020. This led to, or we think that the reason why this trended down already in August and September was because we were rounding already and speaking with physicians, and we were also talking to nursing who started to take those PRN medicines and actually schedule them themselves. Like they would bring them in and put them on a scheduled basis. And also docs were flipping the medicines in there on their own before the order sets went live. Then in November of 2020, you'll see that our mean pain scores dropped. And even for an OBC section to be almost at a 4 at times, 3, 4, as far as their mean pain scores, and come down to in the 2s, pretty happy with that. We also dropped our MMEs. So again, giving less narcotics and also our pain score is dropping. Here's the MME trend by calendar year. Again, I know we're not all the way through 2022, but really excited where those numbers are. And length of stay. Again, even if it's a few hours, we all know how busy OB departments can be. So getting those patients out of here even a few hours sooner opens up a bed for some other people. The next is the urology study that we did. And proud to say this actually update on this one. This just went into publication in the Perioperative Journal of Nursing. So really excited about that. It's an Australian journal. This was the urology study that we did on nephrectomy and prostatectomy patients. And as you can see, day of surgery, pre-ERAS and post-ERAS, this is our total morphine equivalents consumed. So day of surgery, these patients also do receive a TAP block, both pre and post numbers. We've had those since, I believe, 2016. So this was strictly the multimodal put in place. And we have great data, 46.3 in post ERAS 12, day 1, pre 35.9 and post 7.2. So on day 2, 12.2 to 2.2, and their length of stay, 97.2 to 21.6 for their total morphine equivalents. So their mean pain score as well, really pleased with this number. Pre-ERAS, their mean pain score was a 4, and that post-ERAS score is a 2.2. And then for the total prostatectomy and nephrectomy population, their length of stay also changed, which we did not expect because, again, they're not here for very long, 57.4 to 44.5. And I think that's it for me.
Yeah. Thank you, Lindsay, very much. Trying to get my video started. There we go. Great description of what you've got going on in the ERAS world. We're very appreciative of all your hard work. I like knowing that you're always in the background working on these things to make them better. So the next study that we published last summer in June of 2021 in the Annals of Breast Surgery. And if you want to use that QR code, it'll link you to the publication. We published a study looking at the reduction in opioid consumption, pain, and antiemetic use following enhanced recovery surgery protocol after breast cancer surgery, patients undergoing mastectomy. And as I showed on that slide earlier, they got a study out there where, up to 19% of breast cancer patients are at risk for developing new persistent opioid use after surgery. So this is really an important area that we wanted to address. So the aim of this study was to compare postoperative pain scores, opioid consumption, and antiemetic administration among women undergoing mastectomy, both with and without reconstruction, who received either the traditional approach, as I described earlier, that opioid monotherapy, or our enhanced recovery after surgery approach, which is everything Lindsay talked about, including all the non-opioid multimodals in the preoperative period. Intraoperatively, we provide ultrasound guided PEX blocks after the induction of anesthesia to really numb up the whole chest wall, so that during surgery, the patients aren't getting all that sensation of pain going to their brain. And then postoperatively, keeping them on those scheduled non-opioid medications, along with PRN opioids. And so the results of that study, again, we're very proud of. We see Significant differences were found between groups related to pain on the day of surgery and on postoperative day 1. In addition, we saw significant differences on both days, postoperative day 0 and postoperative 1, for opioid consumption and antiemetic administration. And so you can see in this slide, in table 4 there, the traditional recovery group, were consuming morphine equivalents of about 53 on the day of surgery and 28 on postoperative day 1. And we cut those by quite a bit down to 24 and 8.1. So not only a statistically significant value, but also a very clinically meaningful for our patients. So really the conclusion of this study is to provide evidence that the use of this ERAS protocol can not only improve pain management, reduce opioid use, and diminish antiemetic use in patients undergoing breast cancer surgery, but it really shows that a consistent approach to care outlined by this ERAS protocol is strongly supported not only by this study, but in multiple other pieces of literature. So next, I'd like to introduce Emily Saka, the Assistant Director of Rehab Services here at Baptist Health Lexington. So Emily and her team are very integral to everything that we do when it comes to pain management and mobility, and our acute pain service stays very closely knit with them. So Emily, what do you have for us?
Sure. Thanks, John. From a physical therapy standpoint, we have had a long-standing presence in the acute care and hospital setting, where we establish goals for improving kind of overall function and quality of life, particularly with the postoperative patients. Our goal is to increase their mobility and really push someone to their functional capacity. So there's a lot of monitoring how we impact a patient's pain, so much so that we want to make sure that we're providing enough pain management opportunity to enhance that function and really be able to establish a great functional base for discharge planning. I think the best way to really evaluate how these ERAS protocols have impacted therapy services here is to really look at that mobility component of the protocols and how it correlates to the functional goals established by therapists really at all levels of phases of care, and how we work together to find that optimal pain management. ERAS works universally with kind of generalities on a patient's baseline and current function, whereas physical therapists work outside of ERAS to provide skilled assessments that are a little bit more intensive. Our evaluation kind of enhances ERAS mobility components so that the functional limitations are really addressed, and we hope to improve that by the time the patient's really medically ready for discharge. ERAS also assists in utilization for therapy. So setting an expectation of nursing walking with more independent patients reduces the need for that automatic consult on PT order sets with really unrealistic expectations of therapists ambulating a patient 5 or 6 times a day. Ultimately, it really is allowing the interdisciplinary team to have a well-structured pathway of communication on performance and the impact pain with movement, not just walking, has on the postoperative population. Now, we have many veins of preoperative literature supporting increased strength, range of motion, overall functional gains that place the patient kind of in optimal readiness for surgical intervention that correlate to reduced pain. Your intraoperative adjustments from the traditional general anesthesia has allowed safe mobility to occur sooner, as evident in the postoperative orthopedic ambulation, for instance, averaging less than 4 hours here at Baptist Health Lexington. The quick transition from the acute phase into outpatient therapy has really only added to support that physical therapy is a significant player in the multimodal approach to pain management. Now, taking into account quick functional gains and correlation of movement with a reduction in pain, you can see in a very recent article published in JAMA that physical therapy and progressive mobility with ERAS protocols can actually reduce long-term opioid use in the total knee replacement population. So a lot of functional jargon, meaning patients in all surgical service lines are really being encouraged to move proactively before surgery, and that our interdisciplinary team has a collective goal of quick and progressive mobility postoperatively. It also kind of expedites the discharge planning and the discussion with the patient. As Lindsay mentioned, it sets clear expectations on how pain management, along with optimizing function, can help a patient confidently return to the community. Movement not only improves the report of pain, but it can improve the expectation of postoperative pain behaviorally, so that we know that functional gains and improved quality of life they are seeing little by little helps them focus on those small goals and achievements versus having to focus entirely on the pain that they weren't expecting. Now to calibrate us to the issues that we see in the generalized acute mobility and its effects on pain management, we look at the concept that the bed has always been the center for providing care. So there's a strong association between the patients in the bed and the minds of healthcare providers. Even when we recognize the hazards of immobility and write orders that include ambulation, many older adults in the hospital walk slowly, especially experiencing surgical pain. So it's hard to commit the time and resources to make sure that patients are more mobile than stagnant during a hospital admission. This can create a ripple effect of immobility in our community for our primary providers to really manage the compounding effects of weakness and pain. Speaking generally, as we know from the Choosing Wisely initiative of the ABIM Foundation, 65% of the aging population who are independent in their ability to walk lose that ability during a hospital stay. 83% of the time a patient is not moving, and even more alarming is that only 3% of the time a patient is admitted to a hospital is actually time spent on their feet. So collectively, as healthcare professionals, we really have a goal of practicing differently and thinking differently to overcome that long-standing challenge of immobility and its impact on postoperative pain management, which is why through the ERAS system, we've really been able to focus on an interdisciplinary approach to the mobility components of ERAS. AMPAC, or the Activity Measures for Post-Acute Care, has been a longstanding outcome measure and form of communication within the therapy community. Baptist Health and other large systems such as Cleveland Clinic and the Johns Hopkins University Hospital have taken expert experience of therapy in mobility and function and transitioned this tool as a nurse-driven mobility program. This initiative kind of allows our team to have a universal language to communicate on mobility and a unified goal for advancing that mobility while admitted. The nurse plan helps guide an increased frequency of ambulation or activity beyond therapy, which only advances a functional status and allows therapy to really focus on advanced high functional intervention, with more and more patients really being able to reach a discharge to home versus looking at or considering subacute placement because of function and pain. With the increased attention to mobility, we find that better improved pain allows us to have greater functional gains sooner after surgical intervention than we would have if we were to let a patient lay dormant in between therapy sessions. Our team really does understand the spiral effects pain has on a patient's ability to participate. Higher pain levels create self-limitations or apprehension in therapy sessions, which only really exacerbates the risk of functional impairments. Low pain means patients move, more movement means less functional musculoskeletal restrictions that we all know are highly correlated to long-term opioid use. So a great example of this is within the ERAS protocols of the breast cancer service line. We found in an article in 2020 that I guess it's the Journal of Surgical Oncology, And they recognized that 4 to 8 walks daily, starting on the evening of surgery, had a great impact on overall pain management. And there was an analysis of 51 articles that demonstrated positive benefits from exercise in 5 pain-related domains of cancer-related fatigue, physical function, psychological function, body composition, and quality of life. So our ERAS protocol implementation and the ability to communicate using AMPAC across service lines has really allowed our therapy team to focus on shoulder strength, range of motion, activities of daily living, which only promotes improved function and decreased pain outside of that foundational walk around a hospital unit. So overall, mobility is a huge component of pain management. And by allowing an interdisciplinary approach to that mobility and the pharmacological impact on safe early intervention through the ERAS protocols, we have very little pain reports from our patients on an acute basis as well as outpatient basis, which I know really only continues to support our mission to improve opioid stewardship within our communities, which I think Dr. Borders is going to be speaking on next.
Thanks, Emily. I appreciate that. It's amazing that, we often think about how we manage pain really from a pharmacologic standpoint, and there's so many other ways we need to be thinking about that. And so the mobility piece that you discuss is really important, very, very much so. So thank you for that. So now the next stage that we want to talk about is if we've done all this really good work to take good care of these patients in the hospital, but then we send them home with some very large opioid prescription. We're really dropping the ball. And so I want to just, say that there's been strategies to utilize to prevent opioid misuse and diversion. And some of those are really preventative strategies, looking at legislation and education of prescribers to reduce those numbers. Up in Michigan, they've got the Michigan Open and Prescribing Engagement Network, where they give, evidence-based, patient-reported opioid prescribing guidelines that say, hey, if you're having your gallbladder removed, most patients will only use 6 pills. And so maybe we only need to send them home with 10 and these kind of things. So there's a lot of work being done in that arena to kind of help us understand what's an appropriate amount of medication to go home with the patient. And then protective strategies will focus on the safe and timely disposal of those opioids and the safe storage, which we'll talk about next month. So I want to let Dr. Borders, our Chief Medical Officer, really describe some of the work that he's done on the prescribing end. Dr. Borders.
Thank you, Dr. Edwards. I appreciate the introduction. And even though I'm in administration now at Baptist Lexington, I was in private internal medicine practice for a number of years, 33 years before entering administration. And while we are placing a lot of our emphasis on proper prescribing of opioids in the hospital and the ways to minimize their use in the hospital, I think those of us on the outside who practice in the community have to accept the responsibility that most of the improper prescribing that contributes to opioid abuse and misuse is probably as a result of some of the prescribing habits of our outpatient providers. Still, we recognize that the in-hospital role is something that can often initiate a problem by well-meaning providers who may not fully understand the implications of their prescribing behavior. Alongside the Opioid Safety Committee that started meeting, 3 years ago, Dr. Edwards led our hospital's acute pain committee meetings that occurred separately and looked at the literature that was available to help us decide on best practices for pain management. One thing that we did discover quite early into the process is that the research that guides good opioid prescribing is very scarce, and that research that has been done is quite recent. The comments were made earlier, and John did comment that greater than 70% of prescribed opioid pills are unused by patients. And one thing that we want to tell all of our prescribers is that prescription size is the strongest predictor of patient consumption. Patients tend to interpret larger prescription volume by a surgeon as an expectation and intention for use. And there's a common notion among surgeons, if you ask them, that by giving a larger prescription, they think that there's a lower likelihood that they'll be called for a refill, but there's good research that shows that there is no correlation. Patient satisfaction, in fact, which is something that we're all quite focused upon, is actually adversely affected by prolonged use of opioids. One could argue that more use indicates a use of a greater degree of pain, but there's evidence that suggests that the pain quality after any form of trauma, which of course includes surgery, goes through a metamorphosis in no more than the 48 hours that makes the pain quality different and not well managed by an opioid. We have to keep in mind that opioids have adverse effects on appetite, constipation, emotional well-being, and actually it creates a generalized dysphoria. Actually, there's some research to suggest that only those patients prone to the euphoria as a secondary gain would find or call the use of ongoing opioids after 2 to 3 days beneficial. And of course, these are the very patients in whom you want to avoid their use. John mentioned earlier that about 6% of surgical patients become new persistent opioid users, and many continue to use their opioids for reasons other than surgical pain. There was a study in July 2019 published in the Journal of the American Medical Association involving about 58,000 injured workers who received opioids after injury and who were opioid naive at the time of their injury. In this group, about 4% began long-term opioid use. Long-term opioid use was associated with receiving, that was defined, it was associated with receiving 20 or more days supply in the initial opioid prescription. If you compare the likelihood of having developed long-term opioid use between those who received a 20 or more day supply of opioid versus those at 5 days, there was a 29-fold difference. There was a meta-analysis published by the Agency for Healthcare Research and Quality that included 2 studies actually that evaluated the effectiveness of the use of risk prediction instruments and found that they really made no difference. Early into our acute pain management committee meetings, we considered the possibility of creating an instrument that would predict who may be at highest risk for developing an opioid misuse or disuse, improper use condition, and ultimately abandoned that. We felt that when you think about it, we should consider anyone at risk. And given the fact that opioids are generally overrated for their effectiveness in pain management after 2 or 3 days of trauma, we felt that we should simply assume that anyone is at risk and do whatever we could do in a multimodal approach to try to avoid putting a patient in the position of developing an opioid abuse disorder. As I mentioned, research in guiding practitioners' use of opioids is very scarce. And I think if you talk to any physician, certainly anyone who's been out of medical school or out of medical training for a period of time, if you ask them how they learned how to prescribe, it wasn't based upon any best practice that was widely disseminated. It was more than likely based upon something they had watched a mentor or a colleague do, and they simply copied it. It had never gone challenged, and that's simply that developed a process that for many continues to this day. I'm mentioning here alternatives to chronic opioid prescribing for chronic pain, and frankly, this meeting really isn't long enough to really consider the multiple alternatives to opioid therapy, but I mentioned respond quickly because, as some of you may recall, when there was discussion of considering pain as the 5th vital sign, there was one of the major tenets of that claim was that if you did not respond to pain quickly, that the pain would quickly become integrated. It would become imprinted in our neurologic system. We still believe that that's true, but using opioids as a way to circumvent that is not a wise thing. But generally speaking, we do want to respond to the presence of pain quickly. Now, I can certainly tell you that our group of anesthesiologists and with John Edwards' leadership has been very aggressive in local block therapy, both in teaching this method in their side activities of their educational company that they've developed, but also they've actually gone into our emergency room, shown our emergency room physicians how to put in nerve blocks that are effective for hip fractures. Numbing the nerves is not only performed by local blocks, but we've developed, there is a new nerve freezing technique that our anesthesia group is experimenting with. It's primarily focused upon total knee replacement cases, but we're looking at other situations that may benefit from this new therapy, which involves freezing the nerve where the external elements of the nerve will die away and regenerate over a number of weeks, during which time the nerve is functionless, but the nerve does not die. The nerve will regenerate. Now, RICE refers to rest, ice, compression, and elevation, and those are time-honored treatment methods that reduce inflammation and pain. There has been some recent controversy discussed about the use of ice, which may slow healing because of the effect on circulation. But generally speaking, those remain time-honored non-opioid ways of reducing pain. And of course, as Emily Sacco detailed, activity is a huge element of effective pain management. One thing that we are proud of at Baptist Lexington is with all of the efforts to reduce the use of opioids, we have not found an increase in pain. As John mentioned, we certainly do not want to do what we're doing at the expense of increasing our patients' suffering. As I alluded to earlier, opioids are overrated. When you think about the kind of relief they provide, they are effective in the very acute setting with acute trauma. But as we all know, after we've experienced trauma, trauma undergoes a metamorphosis that changes the kind of experience it is towards something that a medication or a strategy other than the use of opioids is more effective in managing. If you continue the opioid beyond that point, what you're more likely to absorb is the adverse effects of opioids that I mentioned. The constipation, the dysphoria, just a grouchy patient. And when we're trying to enhance our patient experience scores and trying to impress them that we care for them, it's important to realize that opioids start working against those efforts very quickly. And so the quicker we can move on to other non-opioid therapies, the better off the patient will be in the long run, the happier they'll be with you. One thing too is, I alluded to it earlier, but a surgeon who gives a larger prescription of opioids is telling their patient that you're going to need this medication longer. As I said, when a surgeon gives a smaller number of opioids, what's discovered is that the patient will use a smaller number and they do not call earlier than they would have with a larger prescription. But if they're given a larger prescription, they're basically given permission, even the recommendation to take them. And by that long prolonged use, as in that study that I mentioned in JAMA in July of 2019, you are greatly increasing the risk that they'll fall prey to the secondary gain effects if they're a person of a personality type subject to those secondary gain effects that predispose them to an opioid disuse disorder. And John, with that, I will turn the Mike, if you will, back to you, but I appreciate the opportunity to discuss these things with all of you.
Excellent. Well, thank you, Dr. Borders. I appreciate your support in all of our efforts that we've tried to do, especially on that prescribing piece. So, what does the future hold really for what we're talking about? And I think the next phase of this, we're seeing a transition to something that's called transitional pain care. And transitional pain care is focused on treating patients who are at risk for transitioning from acute to chronic pain after surgery, with the aim of preventing the development of chronic post-surgical pain or persistent opioid use and the related disability that ensues. So transitional pain care involves a multidisciplinary and coordinated treatment approach that begins prior to surgery and continues during the post-operative recovery period and after hospital discharge, even long beyond hospital discharge. The transitional pain service provides not only pre and post-operative pain management for patients at risk for developing these things, but even incurring time with them from 6 weeks to 6 months after hospital discharge. And so there's now a kind of a fair amount of literature that's evolving on the use of a transitional pain service. Most of it's coming out of Toronto, Canada. There's a transitional pain service at Stanford. There's a good transitional pain service in Salt Lake City at the VA. And we've been chatting with these folks, trying to learn some of the things that they're doing and how we can maybe structure a program in the future as we look forward to how we can take this to a different level of care. And really the main goal that we even started with back at the beginning of this lecture was to say, if you're bringing a patient in for surgery who's an opioid naive patient, we want to make sure that 90 days post-operatively, they remain an opioid naive patient so that we've not created a new persistent opioid user. And even those patients who kind of chronically use opioids prior to surgery, maybe you've got someone who's taking a couple of Percocets every day and their daily oral morphine equivalent is around 30, but they're functioning well with that. They're working every day, they're contributing to society, they're contributing to their family. But now we bring those people in for surgery, and there can be a whole nother challenge with people who are chronically on opioids. But what we don't want to see is that now 90 days post-op, those people are now have a new norm of maybe 90 or 120 oral morphine equivalents a day. So really the role of this transitional pain care in the future, you guys will see this evolve over time, is to try to prevent those things from happening. So we've reached the end of our time with you guys. We're happy to stay on and answer questions. And I want to thank our panelists and Emily Henderson for supporting us in this.
Okay, great. Thank you so much, Baptist Health Lexington team. This has been a wonderful webinar and definitely a multidisciplinary approach for treating opioid stewardship and for treating our patients. At this time, please feel free to unmute your lines if you want to ask a question directly to the panelist, or feel free to use the chat box. I did put the Kentucky SOS website address and my email address if you have questions. Also, Stacy Allen, who's pharmacist. Notice on your screen while you're typing your questions, the continuing education information for this webinar. Continuing education will be provided for pharmacy and nursing. The access code is on there. It is case sensitive. Notice the portal will close on July 23rd at 11:59 Eastern Time. Once this closes, you will not be eligible for continuing education. This portal will not open until 3 p.m. today. Also, Kentucky SOS is also proud to offer continuing education for physical therapists that are on the line, and we'll get that information on there. Are there questions at this time that you have for the panelists? Either feel free to chat in the box or ask online. Okay. These, as mentioned at the beginning of the presentation, the slides and webinar recording will be posted on the website, Kentucky SOS website, for your reference and to share with colleagues. About a week after today's webinar, I will send to all project leads and all the facilities the slides and recording. Also, if you are not on the Kentucky SOS email distribution list and would like to be, please let me know. And the next webinar will be July 28th at from 2 to 3 p.m. Also, calendar invites will be sent closer to date. Are there any last minute questions as we top the hour? It looks like there's some chat. Oh, the panel, you're getting lots of kudos. Yes, and we will post the CE information again, Cindy, for the pharmacy and nursing on the screen. I can also, you can email me and I will send that directly to you at ehenderson@kyha.com. Thank you again to the Baptist Health Lexington team for presenting today and your time and willingness to present and educate us on this perioperative opioid stewardship, absolutely changing the culture. So if there are no further questions at this time, we will conclude the webinar. Thank you, and we look forward to learning with all of you very soon. Thank you.